A very good evening. Good evening to you all. And I welcome you for the first scientific meet for the session of 2022 and 2023. And I would like to invite our secretary to garland our president on dais. Dr. Debashish Das, please.
Good evening, friends. I congratulate the scientific subcommittee for organizing such an beautiful meetings, both online and offline. There will be huge gathering, as I see from the beginning. I also convey our thanks on behalf of OSWB. The speakers, especially internationally renowned people, are over here. So please enjoy this meeting. Thank you.
A very good evening to all the members present in this hall today. It is my honor to initiate the first scientific meeting in this tenure. Let me welcome the entire galaxy of national faculties, namely Dr. Namrata Sharma, Dr. Santosh Honava, Dr. Vanati, and Dr. Sweta Agarwal. We are indebted to you for taking time out of your busy schedule and to be with us in this evening today. May we take this opportunity to congratulate Dr. Namrata Sharma for being elected uncontested for the post of the Chairman Scientific Committee at the national level. We do have an entire brigade of young, bubbling, enthusiastic members who are eager for a platform at the national level. An encouragement from your office, madam, will help them, will catapult them to the next level of efficiency. Our new subcommittees had already chalked out the programs for the entire next 1 year, and this will be available on the website very soon. With all the national thought leaders present in this hall tonight, let me express that we at the state level would like to collaborate with the national level such that these collaborative efforts helps us and our youngsters to go to the next level. Thank you. With that, I hand over the entire program schedule to my Chairman Scientific Committee, Dr. Rupak Kanti Biswas. Rupak.
Thank you, our Secretary and President, for the encouraging words. I will request now, there is a slight change. Dr. Sohom is not able to come. So today's program and moderator will be Dr. Sumana Chatterjee. I'll hand over the podium to you, Sumana.
Thanks, Dr. Rupakante Vishwas. I extend a very warm welcome to all of you and a very good evening to all of you. Without delay, I will start the scientific program. May I please request our respected chairperson, Dr. Shamar Kumar Bashak, to please come on the dais. Our panelists, Dr. Bhaskar Rai Chaudhuri. No, he is here. Dr. Tuhin Chaudhuri. Professor Dr. Sanjay Chatterjee, sir. Please. I think Dr. Mona Bhargav ma'am still not come. Sir, we'll start? Okay. I will request our first speaker, a very dear person and a fantastic auditor, Dr. Sweta Agarwal. She is a senior consultant of Shankar Netralaya, Chennai, G. Shitalakshmi Memorial Clinic for Ocular Surface Disorder. And she is one of the 3 pillars of the department And not only her work doesn't help only the people going to SN Chennai, her work extends to the worst sufferer of ocular surface disease throughout the country. So very warm welcome to Dr. Shweta Agarwal, and I invite her for her talk, very important and practical topic on allergy, vernal conjunctivitis.
A very good evening. Thank you, Sumana, for the sweet introduction, and thank you, Dr. Rupak, for this kind invite. So I'm Shweta from Shankar Nethralaya, Chennai, and I'll be speaking today about the role of cyclosporin in vernal keratoconjunctivitis. Well, we all know that vernal keratoconjunctivitis is a chronic bilateral allergic disorder which affects children usually in their first or second decade of life. The incidence is actually quite high, especially in children reporting to the hospitals. We do see a lot of geographical and seasonal variations. Well, based on the signs and symptoms, VKC has been classified into different grades based upon how frequent the symptoms are, how severe the signs are. Let me take you through a few examples to see how these cases are graded and how best we manage them. Well, to begin with, a mild case which has usually symptoms only during seasons. It could be either summers or winters when these children become symptomatic, and most of them do very well with just a dual acting agent, something like an olopatadine or L-caftidine or bipotastine. However, you slightly have some moderate cases where the symptoms are a little more persistent. These patients will present with papillary reactions or a superficial punctate keratitis, and these, in addition to your dual acting agents, will also require intermittent topical steroids. However, once the symptoms become more persistent and the grade of the vernal keratoconjunctivitis becomes more severe, the corneal involvement starts. These patients can present with recurrent shield ulcers because of giant cobblestone papillae, or the chronicity of the disease, the constant itching, can result in keratoconus in these patients. Some of them also present to you with a bilateral limbal stem cell deficiency. These grades of severe VKCs is what we called as the refractory VKCs. These are patients who present to you with persistent symptoms. They have vision-threatening complications, like we just saw a few of them, and all of them are steroid dependent. So the complications that we see in patients with refractory VKC are not just disease related, but also related to the treatment that they are on. So they can have corneal complications that we just saw, that is keratoconus, or a bilateral limbal stem cell deficiency at a very young age. Or because, as I said, these patients cannot be taken off the topical steroids, and if they turn out to be steroid responders, you have them coming to you with, in fact, end-stage glaucomas and even cataracts. So what do we do? What we actually need is a steroid-sparing agent, and this is actually where the role of topical immunomodulators comes into play. Now, how do we choose? We have such a huge spectrum of immunomodulators that is available. Now, what helps us decide is the basic etiopathogenesis, or what causes your vernal keratoconjunctivitis. We all know that VKC is caused by an IgE-mediated mechanism, but the Th2 dependent mechanism also plays a significantly important role in its etiopathogenesis. And it is this Th2 dependent mechanism which results in the chronic complications in most of these patients. The calcineurin inhibitors like your cyclosporin and tacrolimus act on this arm. They both have similar mechanism of action. However, they are very chemically distinct. Tacrolimus is considered to be a little more potent than cyclosporin. When we come to the mechanism of action of cyclosporin, it basically blocks the Th2 lymphocytes. It inhibits the release of histamine from mast cells as well as the basophils. It reduces your eosinophil recruitment and has an effect both on the conjunctiva as well as the cornea. So basically, it affects everything that causes VKC. It's available in different concentrations, right from 0.05 to 0.5 to 0.1 to 1 and 2%. The formulations are, again, earlier it's known to be lipophilic. So earlier it was available only in castor oil or maize oil, but now you also have cationic emulsions, anionic emulsions, and now the aqueous buffered solutions, also nanomycels and ointment. Preservatives, yes, we do have multi-dose preservative-free bottles which are very handy, like the one which Cyclosis uses, which is the ACBAC model, or you have single-use vials. or preservatives like ethanol and BAK, which is usually not recommended because the disease is a chronic disease and you don't want the toxicity of preservatives to further add on to the inflammation caused by the disease itself. There was this very interesting study which was done on rabbit eyes where they tried to compare the bioavailability of different formulations that is available, and they found that the aqueous buffered solution has the best bioavailability as compared to cyclosporin in oil versus emulsion in oil preparations. Now the dosing, well, it again depends upon how severe your disease is. So it could be 0.05% 4 times a day, 0.1% twice a day, or 2% twice a day. Well, stinging and burning are the two most common complaints that the patient comes to you with. Again, this is more commonly seen in patients who are using oil-based formulations as compared to the aqueous buffered solutions. Well, as of now, no systemic complications have been reported because the absorption is absolutely nil. Now let me take you through a few case scenarios to show you how cyclosporin helped us in our practice to manage a few of these severe or refractory VKCs. This was a child who presented to us with a mixed VKC, had persistent symptoms, and in fact had developed keratoconus. It was difficult to get the patient off topical steroids, so we started the patient on topical cyclosporin 2% along with oloparidine. The patient's disease activity is very much under control. Once the activity came under control, the patient was taken up for a CXL in the right eye and underwent a DALC in the left eye. It's been 5 years. The child is still on cyclosporin 2% and is maintaining a disease-free eye and is comfortable. Another patient, a case with a bilateral limbal stem cell deficiency, a severe case of VKC with no other systemic ailment. Again, very difficult to get these patients off topical steroids. He was put on topical cyclosporin 2% along with oloparidine. And for the last 4 years, we've been able to maintain his limbal stem cell deficiency without any further evidence of worsening. And in the right eye, he maintains a vision of 6/9 with a Boston scleral lens. And since the visual axis is clear in the left eye, he maintains a vision of 6/6. There was a very interesting study where they compared 0.1% acrolimus ointment with 2% cyclosporin eye drops in the treatment of VKC children, and they found both to be equally effective. So guess cyclosporin works well. Now let me take you to this another interesting case where this child had atopic dermatitis, which also caused the severity of the VKC to become a little more. So he would present to us with recurrent shield ulcers, giant cobblestone papillae. He was on topical cyclosporin 2% along with the dual-acting agents. And in addition to that, we had also put him on topical tacrolimus for his skin. However, the disease refused to come under control, which is when we sought the help of the dermatologist, and the child was put on oral cyclosporin now. Now with that, both on topical and systemic cyclosporin, the eye is quiet, the atopic dermatitis is very much under control, and we are able to maintain his vision. So systemic cyclosporin is indicated in children where they have systemic comorbidities like your atopic dermatitis or allergic rhinitis. Well, you need the help of a dermatologist or a pediatrician to help you monitor the disease and the blood levels of cyclosporin as well. Well, just to summarize, you do have a high incidence of severe or refractory vernal keratoconjunctivitis in tropical countries, especially like India. They result in vision-threatening complications, a few of cases that we just saw. And this is where the role of cyclosporin comes in. It not only helps us to control the disease activity and control that part of vision complications, but also the treatment-related complications that are seen in these patients which are steroid-induced. The dosage, formulations, concentrations all depend upon the disease severity. I would like to take this opportunity to invite all of you all to OSCON 2023. It is an ocular surface keratoprosthesis conference being conducted at Shankar Nethralaya in Chennai from the 25th to 27th of August. Thank you. This is my team.
Thank you, Shweta. Very nice illustrative cases, I must say. It's believed that after 2 years, it is safe to use cyclosporin, or can we use it earlier in children? Can we use it?
So usually, Sumina, the onset of VKC is usually not seen in children before 2 years. You know, it usually when we start seeing VKC is only after 4 to 5 years.
Right.
So I don't think we really have a literature evidence to tell us whether we can use it before. But luckily, we don't see vernal keratoconjunctivitis at such a young age.
Right. Any questions to Dr. Shweta?
We did start with 0.05 or 0.1, but in the ones that I have shown you are most of the severe cases. So in the not so severe ones where the children are steroid dependent or are steroid responders, we have tried using 0.05% 4 times a day.
So do you think the efficacy will be same because 2% you are using twice a day?
Correct.
And 0.05 four times a day.
Correct.
Now, will the efficacy be same in long term?
It should be, but as I said, you can always increase the frequency. So these are doses which can be tailored, because we don't have a study or a literature support to tell us that this is it. You cannot increase the dose or you cannot decrease the dose. So based upon how your symptom is, how your patient is responding, you can tailor or modify the dosing. But 0.05% 4 times a day is good.
Okay, thank you.
So like I showed you, one of those cases where it's been now almost 5 to 6 years that we've been using topical cyclosporin, and since there are absolutely no study reports where they talk about a systemic absorption, it's fair enough. Sorry? Absolutely, yeah. So we do have children, when they reach the pubertal age and you are, the patient is under your regular care and follow-up, and you see that the frequency has reduced. Instead of stopping it directly, we ask them to taper it and then stop it. Yeah.
Thank you. I will ask.
Lower concentrations.
Absolutely, ma'am. Absolutely.
So in those situations, you have that experience of just taking off the steroids and only continuing this in milder forms.
Absolutely, absolutely. That is one thing, like when you see that 3 follow-ups, you're not being able to get the child off the steroid, the first thing you jump onto is cyclosporin, especially if they are able to tolerate. In fact, sometimes when they come back to us with stinging and burning sensation, we usually tell them to put the bottle in the fridge, so that once they put the cold, the temperature drops a little bit and the drop becomes a little cooler, that stinging also goes away. So they're very comfortable using the drop as well.
You can taper off the steroid also.
Absolutely. None of these children are on steroids.
Thank you.
Madam, regarding systemic administration, you have told in certain cases you have to use systemic. Any specific side effects for systemic?
So the dermatologist with whom we usually give, what he has, we do see children having gum hyperplasia and complications with cyclosporin, but which is why I said it's always better that we have a pediatrician or a dermatologist who monitors the cyclosporin levels with us. So the dermatologist that we practice with usually practices in a way where he gives oral cyclosporin for 3 weeks and then gives them 1 week off. So that he believes takes down the toxicity level. So right now we have around 5 children who are on cyclosporin, and they are under our care for almost 3 years now at different stages. And as of now, touch wood, they have not had any complications. But this is what, after discussions with a dermatologist, is what he suggests, that if we keep 3 weeks on and 1 week off, it takes care of a lot of complications that can occur because of cyclosporin. But they need monitoring of the blood levels as well. Correct. 3 weeks continuous and then 1 week off, then again 3 weeks.
Any minimum age to start the systemic?
So my youngest child who is on cyclosporin is a 7-year-old girl.
Okay, Shweta, last question. When did you switch over to tacrolimus instead of
So the first thing would be if the child is just not comfortable using the drop, despite keeping the drop in the fridge, if the child says that, they are not able to use it. And technically speaking, they do say that tacrolimus is more potent than cyclosporin. So if we are not able to control the disease activity with topical cyclosporin, and there is no other systemic pathology which counteracts to it. So, we have taken care of all the other parameters, change of place, change of weather, no other systemic pathology like rhinitis or dermatitis, then yes, we will shift the patient to tacrolimus and see how the child is doing.
No, do you feel that this tacrolimus will be effective if patient is having GPC, giant papillary conjunctivitis? In that cases, this papilla will be reduced in size with tacrolimus instead of cyclosporine.
No, so
feel like
to be
that?
very honest, giant, your HT dots, severe, when you have an active disease, you need topical steroids. Topical steroids cannot be replaced when you have active disease. The topical cyclosporine and tacrolimus are basically steroid sparing agents to prevent the recurrence or to reduce the number of times the child will have an activity. But if you have an active disease, you need steroids. The primary role of these in our practice, that has been our experience, is it will help reduce the frequency of the activity that comes in. So the dependency on the steroid reduces.
Thank you. Thank you so much, Shweta. I think we had a very lively discussion, and I'll request Dr. Mona Bhargav ma'am to come forward and sit in the panelist's chair. And I take immense pleasure in inviting Dr. Namrata Sharma madam for her talk, and she needs no introduction, so I will invite her for her consecutive 2 talks. Welcome, madam. Welcome in Kolkata.
So at the outset, I would like to thank OSWB for inviting me here for their first program in this new year. Thank you so much, Dr. Paul, Dr. Rupa Kanti Vishwas, and Dr. Debashish Das. It is always a pleasure to come to Kolkata, feels like a second home. And I promise you that the representation from OSWB for not only young but all the ophthalmologists would be better than what it has been before if I come and if I make the program for the AIOC. So thank you very much for inviting me here. The first talk is going to be the sponsor's talk, and this is the role of preservative-free cyclosporine in dry eye. We all know that from North and East India, we do have data which varies of dry eye between 18.4 to 54%. And this is our study on prevalence and risk factors of dry eye, which shows that moderate to severe dry eye occurs in hospital-based study in almost 80% of the cases. Dry eye immune reaction is initiated by the stress response of ocular surface epithelial cells to desiccation and increased tear osmolarity. And because of this desiccation stress and increased osmolarity, the antigen-presenting cells get activated, migrate to the lymph nodes from wherein the T cells are activated further. And this leads to the problem of the dry eye because the cytokines, they get released. So cyclosporine basically acts at the level of the T cells, and it causes prevents the T cells from getting into action. And it basically binds with cyclophilin so that the entire cascade is broken, and the interleukins, as well as the MMP3, MMP9, etc. are not able to act. Now, if we look at the treatment algorithm of dysfunctional tear syndrome, which is given by the TFOS DUCE 2, level 2 onwards, the topical cyclosporine A role comes. And it takes about 3 to 6 months to see the maximal effects, although many patients begin to experience the results within first month of therapy or within about 6 weeks. As Shweta has already mentioned, there can be oil-based formulations, preservatives or unims. There are problems with each of them. Oil-based emulsion because of decreased bioavailability, because castor oil is used, and also because of the stinging and the burning eye sensation. Benzalkonium and ethanol both tend to be cytotoxic, especially to the epithelial cells. And ethanol also releases the pro-inflammatory cytokines. Now, the preservative-free aqueous-based cyclosporine, which is prepared by the novel proprietary lipid technology, is a biomimetic natural lipid which enhances the solubility and stabilizes the lipophilic cyclosporine A in aqueous base. And this basically, when you put it onto the ocular surface, the lipid component is washed away with the tears. So the cyclosporine component remains on the ocular surface, and it acts and enhances the drug bioavailability as well as addresses the delivery challenges. So if you look at the levels in the conjunctiva and cornea, these are quite high, and it is also tolerated well, and it enhances the patient compliance as well. It comes in the multi-dose eyedropper so that it cannot backtrack, and so chances of contamination are much less. And this is the drug, that is the Cyclysis PF, the cyclosporine ophthalmic solution 0.0 5%, which is truly preservative-free aqueous-based cyclosporin, as of now amongst the various cyclosporins which are available. Now, this systematic review looked at the meta-analysis on the randomized studies on topical cyclosporin A for dry eye. It looked at 11 RCTs and showed that cyclosporin had better tear breakup time, fluorescein staining score, and the OSDI. But if you look at the adverse events in the form of stinging, the adverse events were a little more, but rest of the other parameters, as mentioned earlier, were found to be better than the artificial tears. And this again is a busy slide, but it tells you in nutshell what and where the cyclosporin has found to be effective in the various studies. Now, this is an important study which looked at efficacy of cyclosporin 0.05% simultaneous versus sequential use. So, in one set of patients only cyclosporin was used, and in another set of patients only artificial tears was used. And then subsequently these were put on cyclosporin. Now, it was basically found that at the end of 1 year, the patients treated with cyclosporin A showed significant improvement in Schirmer's score, tear breakup time, and ocular surface disease index, OSDI, as compared to the artificial tears. And patients which were treated with cyclosporin A in the second year showed improvement also in the various parameters. But patients who were switched to artificial tears from cyclosporin A worsened in their dry eye. So I think that question remains as to how long the cyclosporin, topical cyclosporin A, needs to be continued and when you can stop it. Again, on the goblet cell density, if you look, the effect is found to be beneficial, and it is important to use it in the milder form, because once the T cells they get activated, then it becomes very difficult to remove the T cells from the lacrimal gland tissue. So rather than reserving it for severe cases, it is best to give it for mild to moderate cases. This was our study on 0.05% topical cyclosporin, where we looked at 80 eyes of 40 patients. And in moderate dry eye patients, we found that the subjective symptomatic score was improved. And in severe dry eye patient, we found that the conjunctival staining score, subjective symptom score, as well as the tear breakup time was also improved significantly. And this is just to show cases from that cohort. So if you look, the inflammation is decreased. If you look at the cases 3 months after topical cyclosporin, which have been stained, and the similar findings were also seen in the impression cytology. And this is yet another 2 cases where the inflammation does decrease. Now, this was a one-eyed patient where it was used topical cyclosporin A 0.05%. Again, the symptoms as well as the Schirmer and the breakup time did decrease. And this was a case of dry eye with filaments, and this is post-treatment with topical cyclosporin A. As far as LASIK is concerned, again, it has been shown that it does help when you give cyclosporin, and in one eye cyclosporin was given and the fellow eye cyclosporin was not given. But visual acuity was found to be better in cases where cyclosporin was given, and also the corneal sensitivity was found to be better in those cases where cyclosporin was used. Now, this is another study of dry eye disease after cataract surgery, where again the parameters such as the Schirmer test and the breakup time improved and showed better results when cyclosporin was used. Likewise, for higher order abrasions as well as for pre-op biometry, it tended to give better results. Now, this again looked at lipid layer and meibomian glands after cataract surgery and found again it to be useful. Now, this is of course far-fetched, and I don't think we really need to use it, but this was just to quote one study. Following pterygium surgery, also people have used topical cyclosporin, and this prevents recurrences after primary pterygium surgery. I really don't know whether it does in long-term studies, and with there is only a single study which has been reported. So to conclude, cyclosporin does inhibit T cell activation and suppress release of inflammatory cytokines, is safe, well tolerated, and not associated with systemic side effects. And adjuvant use with artificial tear gives better relief and improves the goblet cell density, thus reducing patient dependence on artificial tears alone, and sometimes artificial tear alone may not help where cyclosporin has to be compounded. It has shown that it improves corneal sensitivity, enhances corneal nerve degeneration post LASIK, and also can be used following cataract surgery. But again, I would like to say that these are the studies which are available in literature, and to say that it is really required for all cases is difficult at this point in time. Thank you very much for your kind attention. So I think the next talk is more clinically relevant and more surgically also relevant, phacoemulsification in the presence of ocular surface disease. There are no financial or proprietary interests, and coexistent ocular surface disease with cataract can occur in variety of conditions like dry eye, MGD, pterygium, Salzmann nodular degeneration, ocular burns, SJS, and in ocular cicatricial pemphigoid. As far as cataract surgery is concerned, I think I've already talked about it. It is important to minimize the post-op discomfort in these patients. So one has to detect it prior to phacoemulsification, optimize the ocular surface again before surgery, take intraoperative measures to prevent the surface damage, and post-operatively management should be done to optimize the results. So detection of patients with ocular surface disease would of course begin with history taking, ocular examination, and one has to do a good slit lamp evaluation to look at the inferior fornix and tarsal conjunctiva, bulbar conjunctiva, cornea, and do the diagnostic tests which are required. This has more so become important when you are using the premium intraocular lenses. This is of course the ocular surface stress test. In high risk patients, you put a single drop of mediatic and anesthetic, wait for 30 to 60 minutes and examine for any punctate keratopathy. Then these are the levels of dry eye which can occur before phacoemulsification, and the treatment can be given as per the TFOS dues to classification. And after this has been treated, one should undertake phacoemulsification, and this is the treatment for the meibomian gland disease. Now it is important to understand that the mainstay to optimize ocular surface is lubricants, and anti-inflammatory agents such as topical surface acting loteprednol can be given, or topical cyclosporin can be given prior to the phacoemulsification, especially if there is dry eye, and some people also like to do punctal occlusion. Now the intraocular lens that we like to put in these cases is monofocal. Keratometry video keratography may be a challenge in these cases, and one should take measures to obtain a proper keratometry and video keratography. And IOL master may help, and if it doesn't, then we have to do biometry with ultrasonic B scan or immersion scan. Now, this was a study to show that topical cyclosporin, topically if you use it in multifocal intraocular lens implantation, it does give good results. Now this I think I will deal with as I come to the surgical videos. First and foremost is pterygium, and I think if it's a small atrophic pterygium, then one can remove it at the same sitting. But if it is a large pterygium which is blocking the pupillary area, or if it contributes to corneal astigmatism more than 2 diopters, then one has to wait for 6 to 8 weeks after the pterygium surgery to do the cataract surgery. Likewise, in Salzmann nodular degeneration, if it is only present in the periphery and keratometry is not too much altered, one can still go ahead and do cataract surgery. But if it is present in the center, then it is best to treat it by PTK first, and again after say 2 to 3 months, then do a cataract surgery. And once you do PTK, you know that hyperopia will be induced by corneal flattening, and then that has to be taken care of in the intraocular lens implantation and the power. Now in ocular burns also one can do this, and again I will be showing the videos thereof. It is important to know that wherever your corneal opacification or haze is present, one has to plan the incision differently. At least one half of the cornea should remain clear from where you can do your phacoemulsification. So for instance, if this is the area of the haze, then temporal incision is planned. But if this is the area of haze, then superior incision is planned. Now this is a case of chemical injury where partial limbal stem cell deficiency is there. And cataract surgery is being done using trypan blue staining of the anterior capsule. And just as you go underneath the rhexis, you have to go in one go, because otherwise if you lose the edge of the rhexis there, it becomes difficult to relocate it. Hydro procedure should be done copiously, followed by nuclear emulsification, irrigation aspiration, and foldable intraocular lens implantation. And because these cases may have thinned out corneas, one can even put a suture in such cases. Now this was a case where penetrating keratoplasty had already been done for a case of chemical injury. So there was a pannus which was present, and this can be removed, and this can be dissected with the help of the lamellar dissector. And once you do that, you can actually see a clear cornea there. And this was a white cataract So sutures could not be removed because this was a recent penetrating keratoplasty. And then capsulorhexis is being initiated. So whenever it gets hazy, put a blob of viscoelastic. So for that split of a second, it will become magnified and will help you to initiate your step. And once the capsulorhexis is done, the cornea is quite clear, and then one can do the cataract surgery as one does in in routine cases. Now this was a case again of chemical injury with Salzmann nodular degeneration, where automated lamellar therapeutic keratoplasty is being planned. So this is the cornea which has been dissected, which is about 250 microns in thickness. And after doing the recipient dissection, the phacoemulsification is being done. And because there is less cornea which is present above the incisions, it might get a little tricky to make the incisions. And like I said earlier, whenever it gets blurry, put a blob of viscoelastic there to see where the rhexis is. This is followed by the nuclear emulsification and irrigation and aspiration. Subsequently, the intraocular lens implantation, and again, because it was blurry and viscoelastic has been put. But when you put the graft, always remember to wash the viscoelastic off, because otherwise it will remain in the interface. And this is the suturing of the graft. This case, of course, was not planned for a cataract surgery because we didn't know there was a cataract there. So this was planned for a deep anterior lamellar keratoplasty, again a case of chemical injury. So as layer by layer dissection was done, it was found that there was a cataract which was present. So at the same setting, you can do it at a later setting also, but at the same setting also it can be done, but some amount of stroma should be there, because you can't do this on a bare Descemet's membrane, because otherwise that will rupture. So the pupil is dilated using adrenaline in this case, followed by the capsulorhexis which is done, and then subsequently nuclear emulsification. Again, this would be hazy, so one has to use a little bit of intuition as to how to do it. The nuclear emulsification is done, followed by irrigation and aspiration, and then a foldable intraocular lens implantation. And at this stage, once you put the lens, then one can take out the last layer which is there just above the Descemet's membrane. So again, when it gets a little blurry, put viscoelastic so you know where the edge of the capsulorhexis is and the lens can be put in position. And this is sutured, and the last layer is removed now after this, followed by the full thickness donor cornea, which is from which the Descemet's membrane is removed, and this is then sutured on with the help of 10-0 monofilament nylon sutures. So the patient did have a visual acuity of 612. Now in SJS again it can be a problem, and again I will show this through the surgical video. Now this is a high risk case for keratoplasty. You cannot do keratoplasty because this is bound to fail. So endoilluminator is being used from inside the anterior chamber intracamerally to see where the nuclear emulsification is, where the chopping is actually happening. And now the endoilluminator is being used outside to actually show you the edge of the rhexis so that you can put the intraocular lens in the bag. Notice again that the incision is here, which is temporal because this half is clear, and nylon hooks have been used to expand your area of visualization. So these aids may be required to get good results. Now this is just to show the results of phaco and SJS. Although they don't get a visual acuity of 6/6, but they do become ambulatory, and if you do grafts in them, they are bound to fail. For instance, again in these two cases, they are doing well with 20/60 visual acuity. Again, in this case, 20/40 visual acuity. And this is hazy, but still the patient has become ambulatory. Ocular cicatricial pemphigoid is again a challenge and is a completely different entity. Suffice it to say that we do need to give immunosuppression in these cases post-operatively as well as pre-operatively. Now this is one case to show how you would do, this is healed keratitis with dry eye, one-eyed patient. And again in this case, just as you go beneath the rhexis, you go in one go. And if you can't see, then you rotate the globe downwards to see that, to pick up that edge of the rhexis there and to complete the rhexis. This is an eccentric rhexis which is being done because there's also optical iridectomy. This is the area from where you can see, also the area from where patient will see. And this is eccentric crater. And of course, always remember to put your retro illumination on, because when you put your retro illumination on, one can see the contrast is better and the grayish fragments are seen very well underneath the orangish glow. Also, it is good to use the second instrument, because these fragments may be hiding underneath the opacity, to direct them to the phaco probe or to the irrigation aspiration probe, followed by a foldable intraocular lens implantation. Now this is just to show some of the cases again, not that they will get 6/6, but they will do well as far as the ambulatory visual acuity is concerned. Now this is again a concept, another concept where you should do peripheral chop, especially when the haze is central. So rhexis is done, which is larger, and do a peripheral chop. So what happens is that the nucleus is not springy. Once you do the peripheral chop, the nucleus becomes like a flat plate sort of a thing rather than a bowl. So it will not spring back into the capsular bag again and again. So once this is done, then subsequently it becomes easy to do the nuclear emulsification. And again, always put your retro illumination on, so that you can see against the red glow as to how the various phaco maneuvers are. And this is the last one, which is to show the use of the chandelier. This was again a very difficult case. The penetrating keratoplasty has already been done in this case. This is followed by the application of the trocar cannula and endoilluminator, which is being used. So you have to put your microscope light off, and there is also a retrocorneal membrane in this. So as soon as you put your endoilluminator on, you can actually see where you are chopping and where the irrigation aspiration of the cortical matter is occurring. Of course, this was again a very difficult case, but subsequently intraocular lens implantation and retrocorneal membrane removal was done in this case, and this case then also underwent a DSEC procedure. So this was the picture at the table, and this was the picture immediately post-operatively. So this I think has been done. So this is our review article on phacoemulsification with coexisting corneal opacities, which essentially gives you the principles of what I have already talked to you, and this is the algorithm for the same. So to conclude, it is important whenever there is any ocular surface disease to treat it first, to take all the intraoperative precautions and modifications, and also post-operative regime needs to be ocular surface friendly, and the patient has to be counseled and given realistic expectations. So thank you very much for your kind attention.
Thank you, madam, for the excellent talk. I think all the aspects of ocular surface disorders have been covered by you so well with such excellent videos.
Thank you.
Thank you, ma'am. Any questions for madam? Sir, Dr. Shamar Vashak, sir, for your comments.
These are excellent videos. These are excellent videos. I think the everything. Only thing that in dry eye disease, any dry eye, either it is aqueous deficiency or evaporative dry eye, if you feel that the surface clinically is not looking good, you see the less movement of your particles on ocular surface with blinking, then just a caution during biometry. So you treat the patients, and I have several examples with pre-treatment biometry and post-treatment biometry. Sometimes the difference is 4 diopter. Sometimes you will not see any cylinder later on. So you plant cylinder, then you see that. I am not talking about the multifocals, those are another separate category. But for monofocal also, there is a huge surprise. So you treat, as you said, that you treat them with proper, as per DUCE 2 guideline, that you start with teardrops, then cyclosporin, also treat the meibomian gland dysfunction, whichever thing you have, and wait for 3 months. Look again the biometry. You yourself see before and after, you will see 2 diopter difference sometimes. So these are the basics. And these surgeries you have to do. But dry eye we often miss in our clinical
Normal
examination.
practice.
That is the only sign.
Thank you, madam. Thank you so much.
Just out of the curiosity to Shamartha and madam also, is multifocal is indicated with severe dry eye or for the general ophthalmologist concern? So should we promote multifocal lenses in case of dry eye, or if needed, then what will be the indication, or which are the condition where should be used or not to be used?
Answer is we should not. You just see the patient, look for a follow up the patient, how the patient is behaving. I have several examples I have put, especially with secondary Sjogren, like with other rheumatic diseases. If you put multifocals, the patient will be doing good for 2-3 years. Then all the limbal blood vessels and secondary LSCD, everything will happen, and dry eye will worsening over a period of time. So I think they will curse you. So monofocal, transparent, not even yellow lens, not even yellow lens. You can give this Ahans kind of lens because that gives a better monofocal, little bit of extended depth of focus, but never give a yellow lens, never give a multifocal. But of course, if the toricity is say 2 diopter or more, then you can. But minor toricity, like many people used to practice 0.75 or more, they give toric IOLs. Here, no. You give plain and simple, do a very good surgery. That is all.
Just one more question to Bhaskar also. So, like, when do you see the surface is dry and the biometry, like the question Shamartha has asked, if you are not happy with the biometry at that present of time, so what should be your presence, the protocol, up to how many days you should wait to giving lubrication, and what stage you feel the biometry is stable and you can believe on that biometry and go ahead for the surgery?
So the main thing to look for is ocular surface damage. So you put fluorescein, and if you see punctate erosions, then definitely you should not do biometry, or if you have done, you should not take that into cognizance. Ideal practice, even for normal people without any ocular surface disease, don't do the biometry on the same day when you have done an AT or a NCT or have examined the patient, put drops, and at the end you have diagnosed cataract and you send the patient to biometry on the same day. That's not correct practice, because you are likely to get errors. Once you have punctate erosions, then my go-to drug is sodium hyaluronate, because it is known to have mucomimetic and epithelial healing properties. So with that you treat as long as the patient has not resolved completely from punctate erosions, because punctate erosions is basically underlines that the ocular surface disease or the dry eye is of the serious type, not the casual computer vision syndrome kind of type. So it has to heal properly, only then you should go. And like Shamartha said, multifocals is a no-no in these cases, because you can't afford to lose any light.
Another thing is that the old teaching was with cyclosporine that it takes at least 110 days to see its action. So it is more than actually 3 months. So you need to see them, because the cycle of the cell regeneration and whatever on goblet cells and epithelial cells, everything, and lacrimal gland. So you have to wait and watch and see this patient. Then you can go forward.
Just one more question to Dr. Mona. So do you think that, during post-operative period, the surface inflammation, so do you recommend a longer period of steroid or a mild steroid to keep them for a longer period of time in these kind of dry eye patient, so that the patient recovery and the symptomatic relief also becomes longer duration?
No, actually steroids would be required to a period of time depending on the inflammation caused by phagoemulsification if it's there. Otherwise we would have to treat with other modalities depending on the severity of the dry eye. whether the dry eye is aqueous deficient or the lipid layer deficiency, depending on, because lipid layer deficiency we would have treated beforehand only by doing the meibography or by detecting clinically also and treating the glands, and then only we would have taken the patient for surgery. But if it's a ATD, then we would do a fluorescein clearance test beforehand. If it's a secondary Sjogren's and everything, then we have to do a punctal cautery if it's a severe dry eye along with the cataract surgery, or before or after the cataract surgery, depending on how much the surface takes to stabilize. Once the surface stabilizes, then only we will go ahead with cataract surgery. Not we will jump. It's not good to jump for cataract surgery first. So we will just stabilize the surface depending on what is the cause of the dry eye, treat it accordingly, and then take the patient. And there is no role of giving steroids for a longer duration of time for treating the dry eye, because we have to switch on to other modalities like cyclosporin or lubricants depending on the type of dry eye.
Thank you so much. Yes, sir.
Immunomodulators are anti-inflammatory also, so you can give that along with your substitutes.
So the question you asked, Rupak, is how long, whether you will give the steroids for a longer duration or a shorter duration in the presence of surface damage after cataract surgery. So we have to remember the steroids is a double-edged sword. And if you are using steroids on a damaged surface, the chances of infection are much higher. And in a damaged surface, you should not also use nepafenac like NSAID, because they are known to cause poor epithelial healing. So you really have to titrate, and nowadays in the kind of phacoemulsifications that is done, you don't get much of an intraocular inflammation. So a soft steroid usually suffices for a short duration and lubricate well, avoid NSAID.
Exactly. So these, yeah. So if you see, these are the few questions which we have raised before, coming. So what are the extra measure we should take in case of severe dry eye or in presence of OSD if a general ophthalmologist doing a phacoemulsification? So like these are the questions we have beforehand. So how early age we can start off cyclosporin? So I think these are the questions which you should know as a general ophthalmologist at this point of time. So we will come to the other questions as the the night progresses. Sorry.
What cyclosporin do? Meaning generic versus
We'll come on that also. Dr.
That's
Sumana.
very important.
You can ask him.
No. I think basically cyclosporin is a molecule it's not a very recent molecule. Cyclosporin was launched by Novartis back in 1990. It was available as Sandmune. Me and Samruddha was one of the first who used to make eye drops of Sandmune, Vasco 2. And Allergan at that time has got liquid film. It's a drug vehicle basically. We used to give that. After that, Restasis came. And very recently, one interesting article has come from Dr. Sally Coe, who is the head of generics from US FDA, that there is no substitute for cyclosporin. So in 20 years, what she has concurred, in last 20 years, starting from lubricant different forms to punctal plug, actually for the best result on the ocular surface, cyclosporin scores highest. And generic version of Restasis has been launched in US last year. And it's a spin-off, actually fraction of Pfizer. And the new company called Viatris, who is a conglomerate of Upjohn and Mylan Pharma. And the director of Viatris is from Punjab, Rajiv Malik. And that is actually, that got US FDA approval for generic Restasis as 1/20th of the price of Restasis. Second very important point is that aqueous base cyclosporin is not approved by US FDA. The last
Sequa was
yes.
Is
yes, but it is a aqueous base nanomycelium form, where the cyclosporin concentration is different. It is not 0.05 or 1, it is 0.09%. Number one. Number two is that only US FDA approved is a macroemulsion form. I think the last molecule to get US FDA approval is Varkazia from Santen in VECTI study and nanotube study.
What is your question to the panelists? And
My
the speaker?
question to the panelists is that if the generics of US are available at the same price of Indian, what will you use?
So the choice of generic versus the
Yes.
the original molecule. That's what.
Number
exactly.
one. Number two, traditionally it is usually castor oil based, the oil based formulation. Nanomycelis is now recognized. There are several other things which has yet to undergo any clinical trial.
Okay.
Particularly the aqueous based molecules.
So the solution versus emulsion. So that is one, and original molecule versus the generic.
So if they are available at the same price, the original and the generic, then obviously people would go in for original. It doesn't matter. Generics are always priced less as compared to the originals. But I think we need to study what would be the clinical outcome of generic versus the original molecule which was there. Because like you see in anti-glaucoma medications, there was a study from RP Center only which showed that the generics were performing about 20% less than what the original molecules were performing. So yeah, so that variability can be there. So I think that is something which one has to, study and see.
Yeah, this is for the first time, madam, the reverse is happening. The generic is launched in US and now they want to plan to launch in India.
There was one point you raised that for all these ocular surface diseases, cyclosporine is the best. There is no substitute, no alternative for cyclosporine.
This is not my statement, US FDA statement.
I understand that, but practically speaking, there are some cases in which cyclosporine
will not work.
Yes.
Tacrolimus works better.
Yes, I do get
cicatricial conjunctival diseases is one classical example where cyclosporine.
There are many failures of cyclosporine. A proportion of the patient definitely they respond good to cyclosporine.
So next talk we will get, the debate will go on, we'll learn with time also 20 years experts, another 20 years will come and we'll learn which cyclosporine is better than other. But we'll go to the next talk. Somona.
So all of us have hugely benefited from this discussion, and I feel extremely fortunate to welcome Dr. Santosh Sonabhas sir, and I think we should give him a great round of applause for taking IJO to such a wonderful height. So all yours, sir.
Good evening. Thank you for the opportunity. I'll be showing a bunch of pictures to help you differentiate which ocular tumors do you really need to worry about. Because sometimes even if you have seen this movie, Good, Bad and Ugly, if you have seen it long ago or if you haven't seen it with a lot of focus, then it's difficult to say who is good, who is bad and who is ugly. Similarly, in your busy clinic situation, everything looks like pterygium, everything looks like penicula, everything looks like conjunctival inflammation, and in that would be hidden something which is sinister. And unless you recognize the diagnostic feature of that particular lesion, you may miss it in a busy clinic. Of course, everybody would like to take off a dermoid, limbal dermoid. We have nothing to worry about, that's what we think. But if the leading edge of the lesion has hydration, stromal hydration, or if there is vascularization, then possibly you need to worry about, because this is going to be a deep-seated lesion. This is going to be beyond the mid-stroma, so you might want to keep something tectonic behind. Similarly, if you want to take off a dermalipoma which is symptomatic, if it has grown hair on it, or if it's cosmetically not looking good to the patient, you have to preserve two structures. One is the palpebral lobe of the lacrimal gland, which would be there, and the lateral rectus muscle. Dermalipoma typically is anterior to the tenons. So as long as you don't violate the tenons, you don't have anything to worry at all when you take off a dermalipoma. So your incision should be crescentric ahead of the palpebral lobe of the lacrimal gland. Then you dissect subconjunctivally until you look at the edge of the lesion, which is in the form of a crevice, and simply lift it off. And when you take towards the lateral canthus, that is where there is perforation in the tenons and it gets into the anterior orbit. There you would cauterize and truncate it. So your plane of dissection is subconjunctival purely. You will not even see the lateral rectus, so you have nothing to worry about. If you have a bilateral pinkish lesion, this is in the same location as the previous one, but this patient is heavily built, short neck, bilateral pinkish lesion. If it's bilateral, you think of a orbital fat prolapse. Now, orbital fat prolapse, if you're not careful, you can damage the lateral rectus because this is purely subtenons. It is not subconjunctival. So your plane of dissection is episcleral. When you lift it off, you will see the lateral rectus, and you should be very careful because you may injure the sheath of the lateral rectus. So there is a difference. And if it's unilateral pinkish lesion like this, then you should think of tumors of the palpebral lobe of the lacrimal gland, such as lymphoproliferative lesions. So the difference is very stark and obvious. This gently slopes down to meet the conjunctiva. This has a nice crevice, and that's how you differentiate one from the other. Going with the similar kind of lesions, if you have a lesion like this by birth in a child, and if it is ugly or if it's causing astigmatism, you might want to excise it. But look at the base. It is absolutely white, and the base is very broad, and it is overhanging the cornea with limbal stem cell deficiency in this sector. And this is called osseous choristoma. When you take it off, it comes off very nicely. But what you would see at the bottom would be a crater in the sclera. If this is full thickness of the sclera, it will go nearly 80-90% of the depth of the sclera. So you'll leave a gaping hole in the sclera behind, which may cause staphyloma. So you need to keep tectonic tissue behind. If you have a lesion like this with waxes and veins, the mother tells that the child has this lesion which comes up, it bursts sometimes, releasing a bit of fluid. That is lacrimal gland choristoma. So lacrimal gland choristoma is nothing to worry about, but you can easily remove it. It is superficial. So these are the 4 forms of choristoma. That is nothing much to worry about. But what is worrisome is this. If you have a bilateral situation where there is cutaneous appendages, a shallow lid coloboma, and complex choristoma, unilateral or bilateral, along with greasy looking nevi on the face, chest and abdomen, and bald patches on the skull. This is a bald patch. Then that is nevus sebaceous of Yardison. This is a cancer predisposition syndrome. And you should definitely worry about it because these patients can develop basal squamous and sebaceous gland carcinoma and multiple visceral malignancies over a period of time. They need to have a baseline investigation of the systemic manifestations, and you need to keep a watch on them on an annual basis. This is exactly how a nevus sebaceous of Yardison patient looks. You may think that this patient has just a nevus, but that's a dangerous nevus. Along with that, this is one lesion where there is cartilage in the ciliary body and also an osseous choristoma of the choroid, which may look like choroidal osteoma. So this is the entire complex of nevus sebaceous of Yardison, and all these features may not be present in every patient. Some of them may be formafrostic. In vascular tumors, you have a long list. This is something which is cosmetically blemishful. Patients will come to you for this, but this may have an underlying orbital varices component. So you have to do Valsalva maneuver and bend down test to detect. If there is no orbital component, you can simply cryocauterize or excise it. This looks dangerous, heavily vascular lesion acquired in an adult. This is capillary hemangioma of the conjunctiva. Simply can be excised without any worry. These patients don't generally come to you with this lesion. This is very tiny. They don't even notice it. But what they notice is subconjunctival hemorrhage, which may occur spontaneously in these lesions. This is lymphangiectasia, or a very small variant of lymphangioma. Only when the blood resorbs would you see an underlying lesion like this, and if subconjunctival hemorrhage were to be recurrent, you might want to excise it and cauterize it. More dramatic manifestation of lymphangioma would be this, with repeated subconjunctival hemorrhage, a variant of lymphangioma which is in the fornix, and it is ugly. So you will either excise it, cauterize it, vaporize it, or currently we inject bleomycin or picibanyl. These are sclerosing agents which will easily take care of this. But what if you have an aggressive lymphangioma of this sort? This patient has an attempted biopsy, elsewhere it bled uncontrollably, hence the surgery was abandoned, I believe, and the patient was referred. You can inject bleomycin, but it is along all the 3 extraocular muscles, medial, inferior and lateral rectus, and it is very close to cornea, so bleomycin may be deferred, and instead of that you can simply vaporize it using carbon dioxide laser or a radiofrequency electrode, and ocular surface can be relayed with amniotic membrane with nice results. So you can avoid major surgery and bleeding in these patients by using laser vaporization. This looks very dangerous, but this patient has forgotten that he has undergone a retinal reattachment surgery 20 years ago. He comes with a fresh lesion of this sort, which is bleeding on touch with a lot of discharge. This is nothing but a pyogenic granuloma. So fiery pink lesions sometimes can be very innocuous, but not this one. This is a young patient who gives no history of being HIV seropositive, is hiding that history, comes with a lesion which is extremely vascular, and it is growing in days. The initial manifestation, he was given topical steroids by the ophthalmologist. 3 days later, it had bled. There was a lot of subconjunctival hemorrhage, diffuse subconjunctival hemorrhage, and this turned out to be Kaposi's sarcoma. So you have to be careful with rapidly growing, highly vascular conjunctival stromal lesions. Why would I call it stromal? Because you see that shine here. It is not an epithelial lesion. It's a stromal vascular lesion, and you should definitely worry about it. In epithelial tumors, you have a list: squamous epithelial tumors, which could be benign, papilloma, hereditary benign intraepithelial disc keratosis. This is typically seen in triracial individuals in the US. It's not our concern, but of course we have OSSN, which is our most common tumor. In papilloma, generally papilloma has a broad anterior surface and a small pedicle and a small vessel in the center with radiating blood vessels. This is very typical manifestation of papilloma. It could be multifocal, in which case you suspect immunodeficiency of some sort. If it is unifocal, unilateral, you don't really worry about it. It is caused by human papillomavirus 16. So typical manifestation of papilloma is pedunculated. But what if it is inverted? The top is small and the bottom is heavy, like this. Top is small and the bottom is heavy. That is called inverted papilloma. Now, inverted papilloma is definitely something you need to take it seriously, because it has most likely manifestation of a squamous cell carcinoma transformation from a pre-existing papilloma. So inverted papilloma configuration is something which you take seriously. This looks fiery, but it is nothing but an aggressive papilloma in an immunocompetent child. For whatever reason, it can be very aggressive as this. This is a Mongolian patient who was referred with aggressive papilloma, which was refractory, with extending through the lacrimal sac into the nose. That is the picture of the nose, and he responded to multiple injections of interferon. Interferon can be used very successfully in managing papillomas. What if you have a patient with what looks like diffuse ocular surface inflammation, red eye? This patient has unilateral red eye. If the patient has bilateral, that is understandable. He has unilateral red eye, which is not responding to conservative measures for a finite period of time. And this is how the ocular surface looks. We think that it could be squamous cell carcinoma, but when you evert the lid, the story is out. He has broadening of the eyelid margin, which is twice or thrice of the normal thickness. He has rounding of the posterior lid margin. Meibomian gland orifices are all lost. His lashes are sparse. So this is pegytoid or intraepithelial variant of sebaceous gland carcinoma. So patients can actually present like this, and we would think that it is ocular surface inflammation because lid is normal. We always imagine that sebaceous gland carcinoma presents with a large nodulo-ulcerative lesion, and unless we look for the lid changes, we are going to miss such patients. So these are the lid changes of sebaceous gland carcinoma. These are some more examples of pegytoid or intraepithelial sebaceous gland carcinoma, where we determine the extent of the lesion by doing what's called map biopsy by the Putterman's technique. Now, if this patient has an exactly similar manifestation, has no lid changes or minimal lid changes, but has these white dots, which are nothing but specks of keratin, then that becomes squamous cell carcinoma. Keratin is a product of epithelial cell turnover, and squamous cell carcinoma has a high epithelial cell turnover. So the moment you see keratin, your diagnosis changes, and that is squamous cell carcinoma or ocular surface squamous neoplasia. It can have many manifestations. There are many phases of squamous cell carcinoma. This is one such where it can be confusing. This was a patient who was treated by a cornea specialist as peripheral ulcerative keratitis, looking at the gutter, etc. Patient underwent conjunctival resection, glue BCL for the thin cornea. He resolved, but what was missed was this patch of keratin, and it did have scleral invasion as well. This is squamous cell carcinoma manifesting as peripheral ulcerative keratitis. This patient presented with perforation at the limbus, no collagen vascular diseases, exuberant keratin. Somebody did a patch graft, and when they sent this necrotic tissue to the pathologist, she diagnosed it as squamous cell carcinoma. It can present as sterile corneal melt. It can present like necrotizing scleritis, but not to miss keratin. So keratin, I'm manifesting, showing again and again, is a manifestation of OSSN. These are the masquerades of OSSN. All these have different phases. And if you look at this typical spectrum of OSSN, each tumor looks different. So when a cat doesn't look like a cat, how can you call it a cat? So you have to look for certain common manifestations, and the common manifestations are keratin. If a patient has whatever it may look like, pterygium, pincula inflammation, but has even a spot of keratin, then you should think of OSSN, because keratin indicates at least has 80% sensitivity for OSSN. That means you cannot diagnose all patients of OSSN using keratin, but when you see keratin, it is quite specific for OSSN. Second pattern is abnormal vascularity. Abnormal feeder vessels and intralesional vessels, intrinsic vasculature. Adding keratin to that would increase your sensitivity and specificity to respectable levels, but not very good. Add to that 1 rupee test, Rose Bengal staining. All these three put together has diagnostic sensitivity and specificity or positive predictive value as good as the gold standard, which is histopathology. So if you have a patient with whatever it may look like, pterygium, pincula, etc., but it has keratin, has abnormal vascularity, and also stains with Rose Bengal, you should treat it with lot of respect and excise it with 4 mm clinically clear margins, because it is most likely going to be ocular surface squamous neoplasia. If you still have any doubt, you can bring in OCT. OCT has revolutionized the practice of medical retina, and so it has the management of ocular surface tumors. So the triad of science is just this, that this is normal corneal epithelium. If the corneal epithelium is hyperplastic and hyperreflective and abruptly ends with a snout-like edge, then that is typical of ocular surface squamous neoplasia. It's been proven, there are studies which show that these are the triad of clinical signs, OCT signs for OSSN. So let's see some of the example. This is obviously pterygium, and sometimes what happens is you excise it thinking it is pterygium, and histopathology turns out to be something different. So the difference is that the pterygium has very stringy, thin vessels which are actually pointing towards the apex of the lesion. Whereas if it were to be OSSN, you see blood vessels at all levels, episcleral, intrascleral, conjunctival blood vessels moving towards the lesion to feed that hungry tumor. So tumor obviously is evident, but look at the caliber of the blood vessels. They are of different caliber, they are tortuous, they are dilated. So that is how vascularization of OSSN looks as opposed to vascularization of pterygium. So abnormal vascularity is a pointer. That's just a fat deposit, nothing to worry about. But this is something to worry about. Again, look, pointing towards abnormal vasculature. So keratin abnormal vasculatures are the pointers to OSSN. The last bit is about pigmented conjunctival lesion. There's a huge list, but I'm going to restrict to 4 top ones. Complexion associated melanosis, primary acquired melanosis, nevus and melanoma, and how to differentiate one from the other. Now, if you go back and look at your spouses or parents, everybody, all of us will have some conjunctival pigmentation. Because we are all Asian Indians, we tend to have what is called racial melanosis or complexion associated melanosis, which may be missing in Caucasian population or green-eyed or light blue-eyed individuals. What happens to complexion associated melanosis? It is bilateral. It is fairly symmetrical. It may not be mirroring in each eye, but it is fairly symmetrical. It has these microfolds such as cobblestone kind of an appearance. It can even have spots of pigmentation in the peripheral cornea. It can have phoenicial extension, but tarsal involvement is almost always not there. So this is how complexion associated melanosis looks. And it can simply be observed if a patient is cosmetically concerned. You can excise that part of conjunctiva or do cryotherapy. But when you see asymmetry, then you should be very worried, because asymmetry means that it is primary acquired melanosis. You can argue that there is some bit of pigmentation. Well, that is commensurate with your gender, age, and whatever, race. But, sorry, not the gender, age and race. Gender doesn't have any bearing. But look at the right eye, it's grossly pigmented. That is primary acquired melanosis. Primary acquired melanosis is a precursor lesion for melanoma of the conjunctiva. Seen in middle-aged individuals, unilateral, flat, no cyst, and has a high risk of melanoma. Depending on which study that you are looking at, the risk of melanoma ranges from 10 to 30%. That's a high risk. And the size of the lesion matters actually. Here, with each clock hour of involvement, there's 1.7 relative risk of it transforming into melanoma. And if you look at conjunctival melanoma data, 75% of conjunctival melanomas have arisen from a pre-existing primary acquired melanosis, which you would definitely notice as an ophthalmologist if such a patient were to come to you. This is a fornical PAM, and not to miss this nodule, that's a melanoma. This is a fornical PAM, and not to miss the melanoma. So melanoma arises from pre-existing PAM. Okay, now this is a set of clinical photographs of 4 different patients. Monday morning when you go back to your clinic, you might have one of these patients sitting in front of you. So which one do you say is a melanoma and which one do you say is a nevus? Can you guess, any of you? If I put it as A, B, C, D, now which one is not a nevus? Can you guess? These are real life situations, right? B and C, fine, so fair. But there is no agreement. If I take a poll of the audience, everybody would think differently. So we have what is called a clinical checklist. If a lesion, pigmented conjunctival lesion, has interpalpebral location, most likely it is a nevus. 90% of nevi are present in the palpebral fissure. Nevi have variable pigmentation. They're not jet brown or black. Nevi have all shades of gray, all shades of brown. All shades of brown, like in the shade book of the painting, whatever painting card or whatever you get it. So you see tan brown to dark brown. All sorts of brown are in a nevus. You can see this picture. All of them have variable pigmentation. They're not uniformly dark brown. So most likely all of them are nevi. Now let's see the other. No corneal epithelial invasion. They just stop short at the limbus. You may argue saying that, well, this has corneal epithelial invasion. No, it is just a fat nevus which is overhanging the limbus. If there were to be corneal epithelial invasion, it would be like this, carrying pigment and vascularity along with it. So corneal epithelial invasion is absent in all of them. No episcleral fixation. You judge that on slit lamp evaluation using a wet cotton tip deplicator. Try to move the lesion on the episclera. If it moves, most likely it is a nevus. Nevi don't have intrinsic vascularity. All of them have feeder vessels, and book write that feeder vessels are not present in nevus, but I haven't seen a nevus without a feeder vessel. This one in fact has 2. Feeder vessels are not a contraindication to the diagnosis of a nevus, but if there is intrinsic vascularity, that means there is a lot of blood vessels within the lesion, most likely you're not looking at a nevus. But the most important feature is the presence of microcysts and macrocysts. Nevi are spongy, so they have lot of microcysts and macrocysts. If you can't clinically see because of pigmentation obscuring it, you can do anterior segment imaging to see microcysts and macrocysts, and if you find that, you're very sure that the lesion that you're looking at is a nevus and not a melanoma. Melanoma is a solid lesion. Clinical application of imaging comes in a patient of this sort. This is a 11-year-old child of very aggressive physician parents who brought this child, very worried that the child has developed something which is abnormal. They noticed it just a week ago, it seems. The child has a fleshy pink lesion with a fat feeder vessel and what looks like some blood vessels within the lesion. It has transgressed the limbal barrier. They have read about it and they find that it has features of a malignant lesion. They're worried about it. So how do you confirm that it is indeed a amelanotic nevus and you don't want to take it off? Again, do imaging, you'll find a lot of microcysts within it. So it's a rare variant of amelanotic lesion, nevus. For whatever reason, it has transgressed the limbal just a bit and it really didn't change for several years until we took it off for cosmetic reasons. What if a nevus transforms into a melanoma? The risk is 1 in 300. But there are real life situations. This is my own patient who suddenly popped up this nodule. So this you see cysts. Here there are no cysts, solid lesion, lot of vessels within it. So this nevus has transformed into a melanoma. Okay, then what about this? This is again my patient. He was missing for 8 years. He went on to do some engineering course and then he came back after several years. He always had this nevus which we had documented, and he has this nodule, dark nodule growing from this nevus with subconjunctival hemorrhage, which was fleshy with lot of feeder vessels. When we did UBM in this patient, you find there are 2 zones. One is a zone with cysts and one with a zone with solid lesion. So this corresponds to the nevus, this corresponds to the melanoma, This is the zone of transition of a nevus into a melanoma. So you can actually see where the nevus has transformed into a melanoma by doing imaging. So imaging is very useful in the management of ocular surface tumors. So finally, which conjunctival pigmented lesion would you worry about? If it is unilateral, this is definitely PAM, no doubt. This kind of a lesion, if it is bilateral, this is complexion-associated melanosis, you really don't worry about it. Extensive unilateral lesion, this could be PAM, you worry about it. This is an interpalpebral lesion, variable pigmentation with one feeder vessel, this most likely is a nevus. This one with lot of aggressive vasculature, intrinsic vessels, transgression of the limbus, variable pigmentation, but this part is very dark and this is pink only because of vascularity. This is most likely a nodular melanoma, you should worry about it. Last bit is about fleshy pink lesions. This is a professor who suddenly comes with a subconjunctival hemorrhage. Once the hemorrhage starts resolving, we find an underlying fleshy pink lesion. Fleshy pink lesions generally tend to be conjunctival amyloid, and this is the apple green birefringence. Today in RIO, one similar case was being shown. This is again a conjunctival amyloid. This translucent fleshy pink nature indicates that it is conjunctival amyloid, and it actually, once you evert the conjunctiva, it starts bleeding on its own. It has a high tendency to bleed. These kind of, you are very familiar with salmon I'm sure in Calcutta you must be eating a lot of fish. This is salmon pink color, correct? This is lymphoproliferative lesion, but you can't be sure whether a particular salmon pink color lesion is a benign reactive lymphoid hyperplasia, lymphoma, or atypical lymphoid hyperplasia unless you biopsy it. So salmon pink colored lesions are typically lymphoproliferative lesions. However big or small maybe, they're all lymphoproliferative lesions and you need to biopsy them. So ocular surface lesion, the dictum is not to worry at all, simply recognize and manage appropriately. Thank you so much.
Thank you so much, sir. You always mesmerize us with your fantastic slides.
Thank you.
And I think we have, all of us appreciated how we should not miss any bus. I think that is the most common thing that we see in the OPD and perturbed by the parents' questions.
Thank
so that is, I have one question, sir.
Yeah.
For this lymphoid hyperplasia, they sometimes do respond to topical steroids.
Right.
So can that make a differentiation for benign and malignant?
No, it can't. Because any lymphoproliferative lesion responds to steroids partially, but it comes back. Right. Benign reactive lymphoid hyperplasia responds to topical steroids. Even lymphoma does. In fact, all the lymphoma chemotherapy protocols have steroids as a common agent. Prednisolone is part of the chemotherapy protocols.
Right.
So steroid response is not an indicator as to whether it's benign or malignant. Any salmon pink lesion has to be biopsied.
Okay, sir. Thank you so much.
Thank you.
Thank you.
20 years following a detachment surgery. Is it related anyway to the silastic sponge encirclage surgery or even the modern three-port surgery?
No, modern three-port surgeries don't cause it. This was related to the suture, there was a buckle there, which had very slowly migrated anteriorly, and there was a suture underlying just there. So that was a suture that had eroded through after 20 years that had caused this problem.
Thank you.
Thank you, sir. Thank you so much. Now I invite Dr. Vanati ma'am to present a talk. She will be talking on the reconstruction of ocular surface after chemical injuries. She is a professor, cornea, ocular surface and refractive surgery from RP Center.
At the outset, I wish to thank the organizers for having me in part of this fantastic meeting. And after a mesmerizing talk by Dr. Santosh Hanawar, I will take you on to certain concepts of ocular surface reconstruction in chemical injury. I have no financial interest in the mention of any products during the course of this talk. And for those of you who do not know me, I am Dr. Vanathi. I am taking care of the cornea cataract refractive services at RP Center, AIMS, New Delhi. So in the next 10 minutes, I'm not really going to run you through all the textbook factors of ocular surface chemical injury, but I'm going to probably talk to you on just the understanding certain concepts in ocular surface reconstruction and what is perhaps is new and it's contributed from researchers in Indian scenario here. So to touch upon classifications, I think we all know that there are multiple classifications of how you would categorize the ocular surface injury because of chemicals here. We've had the age-old Ropohol, we've had the modified Hughes, and of course most of us do follow the Duas classification now, which incorporates the amount of corneal involvement, which includes the limbal ischemia, the limbal involvement in terms of cloacas involved, and the amount of conjunctival tissue which is damaged here. So this is how we have moved on, where the Hughes initial classifications just spoke about whether it's mild, moderate, or severe, not relating the severity of the injury to the outcome here. So the Ropohol was able to sort of link the prognosis to the clinical involvement here. So that gave us a 1, 2, and 3, 3 and 4 with good prognosis for the mild, the 1 and 2 grade of injuries, and a worse prognosis for the 3 and 4 injuries. But still, this again was not able to give a good prognosis or was not able to differentiate or prognosticate between the most severe injuries. So that's when the Duas classification came in, and the grade 4 of the earlier one got further subclassified into 4, 5, and 6, and was able to prognosticate, including the limbal severity, the conjunctival involvement, and this gave a very good analog of the surface, of how the surface was injured. A few representative pictures here where you could see that the cornea here is particularly involved, almost subtotally involved, but you do not see much of conjunctival involvement here. Here you have minimal corneal involvement, but a significant amount of surrounding inferior conjunctival tissue involvement. Here you're having an adjoining limbal ischemia as well. So that's how you learn to correlate, and probably this is of more use for practitioners and for the fellows who are into cornea practice here, where you would learn to categorize the severity of the injury, because the prognosticating those depends upon the severity or severity of the injury when you see them here. So again, a few representative pictures here where you're seeing an extensive corneal involvement, but the conjunctiva is not so badly involved except for the inferior here. Here you're seeing quite an extensive conjunctival, a severe injury here. Here you're seeing there's an extensive blanching at the limbus, so that's a limbal ischemia over here, and this is a surface which has been reconstructed following the injury here. And I think there are fantastic papers on outcomes and prognosis and comparisons of the various classifications. And for those of you who are interested, you could probably go back and read these, and you would know that prompt ocular surface reconstruction by amniotic membrane surgery helps you to give a better prognosis and a better outcome in management of these surfaces which are affected by chemical injury here. So what's new here is, why do you need something new in classifying? It's because there's a change in the way we understand the ocular surface healing. There's a change in the concepts to the surgical management of ocular surface injuries, and again, incorporation of the concept of stem cells in the management of ocular surface injury. So this is a fantastic paper here, and I think we have Shweta with us, who is also one of the authors who's given this concept, and I really enjoyed reading this, where you read about the I's and the E's which change the algorithmic approach, and it also help you to understand the concept of how you would probably manage ocular surface injuries here. The various I's and the various E's is understanding what are the main parameters which are affecting the acute stage of the affliction of the ocular surface. So the inciting agent, the amount of inflammation on the ocular surface because of the injury, the amount of limbal ischemia which is present, and its effect on the intraocular pressure. So these are the eyes which affect the way you're going to look at, or how the algorithm is going to evolve. And the E's are the epithelial defect involving the corneal epithelium, the epithelial defect involving the conjunctival epithelium. So these are the important aspects. And the other is E is the exposure of the ocular surface to because of injury to the ocular adnexia. So understanding this is perhaps going to be important, because you probably need to direct your methodologies to manage these I's and E's, which will help in better prognosticating and which will help in better outcome of the management of your surfaces. So this is a pretty crowded slide here, but this is a fantastic paper which I would refer you all to go out and pull out and read, and it really helps you to understand which procedure you probably will have to apply depending upon the I's and E's on the ocular surface which is causing the damage here. These are some of the publications which have come out from our center itself here, which all talk about the incorporation of ocular surface chemical injury and the role of stem cells as well. What you need to understand is, in chemical injury, it could be an acute chemical injury or a chronic chemical injury. In acute chemical injury, what you probably see is a non-healing, persistent surface epithelial defect involving the cornea and the conjunctiva. So that's when the role of amniotic membrane ocular surface reconstruction comes into play. When you look at a chronic chemical injury sequelae, what you would see is extensive minimal or maximal symblepharon formations, and these are surfaces which are going to need an extensive ocular surface reconstruction here. So again, some of the clinical pictures of acute chemical injuries where amniotic membrane helps in a better outcome of the ocular surface optimizations here. But you also see in chronic cases such as this, where you would probably need to take them on for a symblepharon lysis, removal of the symblepharon, management of the symblepharon, and an ocular surface reconstruction using amniotic membrane. But remember, when you manage these ocular surfaces or reconstructing these surfaces, the two primary aim is to relieve all the adhesions, help in the surface epithelialization, restore the depth of the fornices as much as possible, so that you're able to optimize the ocular surface, and you would be able to visually rehabilitate these patients by taking them on for subsequent refractive corneal lamellar procedures here. So provided the eye has a visual potential here. So those are some of the aspects here. So understanding here, again, I've already touched upon the cicatricial lysis and reconstructing with simple tissue available, which is either the conjunctiva, amniotic, or the mucous membrane, and enhancing the epithelialization of the surface and reconstructing the fornices here. This is a fantastic paper by the Sotosono group, which really helps you to understand when you will have to use only amniotic membrane for surface reconstruction, when you will need conjunctival tissue, and when you will need to add on additional mucous membrane tissue. So understanding these concepts are really important, otherwise you would land up saying, I did an amniotic membrane and there was total failure here, and this would rather worsen the prognosis and the outcome for the patient than it would help him here. So when there is a simple cicatricial here and the depth of your fornices is not so badly affected, a simple surface reconstruction using symblepharon lysis and mitomycin and a little of AMG, it would probably suffice. But when you have a significant amount of skin adhesion and a significant amount of symblepharon, and when you know the available conjunctival tissue is not enough and amniotic membrane is not going to be helpful, these are cases where you will have to go in for fornix formations along with use of adjunct tissues such as mucous membranes, and which will help you in better reconstruction of the surfaces here. So now we do have the concept of limbal stem cells which have come in. So limbal lenticles, either using cultivated limbal tissues or simple limbal transplantations, need to be combined on surface reconstructions in scenarios of acute injuries or in chronic conjunctival injuries for optimizing the surfaces, following which in sequential procedures you will probably have to take up the patient for corneal procedures here. So I'll just walk you through through rapidly through a video here. You find a really bad chemical injury here. The superior fornix is stuck on. So you'll have to recreate these fornices for these patients, remove the amount of fibrotic tissue on these surfaces here. And this is a cultivated limbal epithelial tissue on an amniotic membrane strata, which is being fixed onto the surface where the symboliferon has been managed and then fixated with glue, and you wait for this surface to heal back and come back to as near normal as possible here. So that's one scenario here. I think we wouldn't delve into the surgical nuances of these of scenarios here. The other one is when you go and do a limbal stem cell, a SLET procedure, a simple limbal cell transplantation, which you take from the fellow eye in cases of autologous chemical injuries here, and in the chronic phases here, when the other eye is normal, you harvest the limbal stem cells here, and this is the fellow eye of the patient which needs the SLET procedure here. So you see the speculum itself is not able to go in here, and again you reconstruct, do a peritomy here, minimal removal of the surgical scar or the fibrotic scar tissue here. And once this has been optimized, again I use minimal cautery in these cases and allow the bleeding to stop by itself here. And once you have dealt with the fibrotic tissues here, you reconstruct the surface here by using your the tissue which you have harvested in the patient here. So this is the subsequent video of the same patient here, and after the surface is optimized, put in the amniotic membrane to reconstruct and help in epithelialization of the scarred surface here, and the autologous stem cells are then split into fine smaller pieces, as you can see here, and fixed onto the surface here, and using fibrin glue here. So these are, again, remember, very scarred surfaces, and you're dealing or fighting a war in which the prognosis is not really good. And this is most sad when they are pediatric patients. So, but this is the only option we probably have to reconstruct the ocular surfaces of these patients so that you would be able to provide a visual rehabilitative procedure for these patients here. Of course, tenoplasty is something which I have not covered here, and that's another procedure which needs to be done when you're looking at acute chemical injuries. I think I'll stop here. This is a very long subject, so 10 minutes is not something which is going to suffice to deal with all this. I thank you all for your patient hearing.
Thank you so much, madam. It was an awesome talk. And as you yourself have mentioned the essence work on the topic, and I cannot restrain myself when Dr. Shweta is here with us. I want her to comment on the latest guideline about an app to prognosticate and to diagnose the chemical injury from the initiation and as they progress further. So this is about EPICS. She will update you.
So thank you, Dr. Vanity. That was a wonderful, wonderful talk. And like you highlighted, the basic problem with the DUAS classification that we all experience when we are managing these patients is that DUAS classification talks about the limbal involvement, which is the epithelial loss at the limbus, and it talks about the conjunctival epithelium that is lost. It does not mention about the different I's and the E's that we have already reported to have an effect on the prognosis or the final outcome of patients with chemical injury. So it does not talk about the scleral ischemia, it does not talk about the intraocular pressure, it does not talk about the exposure. So and even the epithelial defect. So it talks about the bulbar conjunctival epithelial defect, but it does not talk about if you have an epithelial defect or a total loss of epithelium from tarsal to tarsal. So these are different parameters which we realize that unless we put it on a chart and we start documenting them in the acute stage, we will not stress on how important they are to manage all these factors in addition to taking care of the epithelial healing. And all these factors do play a role and interfere with epithelial healing. So if you have a scleral ischemia and you don't do a tenonplasty, that defect is not going to heal. If you have a patient where the intraocular pressure is low, there is a hypotony because the ciliary shutdown has happened, you don't put the patient on topical oral steroids, that eye is not going to heal. If you have an eye where there is a total loss of lids, or there is an ectropion or an entropion, the defect is not going to heal unless you take care of exposure. So EPICS is just a grading that we have come forth with to prognosticate these patients, primarily to note down these parameters in the acute stage. It is a dynamic reporting which will change almost every time we see these patients in the acute stage. And it's going to be available just as free as we have the ACS calculator online. So that link will be shared soon. We are just ready with the platform. Probably another fortnight we should be able to share it with everybody. But thank you so much, Dr. Vanti. That was a wonderful talk.
Thank you.
Thanks.
Thank you. Thank you, Shweta. Thanks, ma'am. And now I invite our very own Dr. John Sharkar, a prolific young cornea surgeon from Shushrut, and he will present some cases and he will ask us difficult questions about them.
So, very good evening to all of you. So, first of all, I would like to thank OSWB and Dr. RKV sir for giving me the opportunity to be part of this nice scientific fest. So, I was asked to present some of the cases which are really we are facing day-to-day practices in associated OSD. So, some of the cases are really brainstorming. So, my topic will be discussion on and off surface cry, out of the box. What's my reply? I have no financial interest. So I'm presenting my first cases in surge of pandemic. All red inflamed eyes are not by black bugs. You just sit in your chair and go back to 2 years back. So this patient came to us, a 45 years female presented with sudden onset of pain and swelling in the both eye for dimness of vision with mild fever for 15 days in the May 2021 during the surge of second waves. And she is a known case of uncontrolled DM with under insulin and oral medications, or VCV was right at 6/12 and the left is 1/60. And she has been diagnosed as a left eye preceptor cellulitis by the Ocular consultant and started the IV antibiotics. COVID RT-PCR was negative and clinically generalized toxic looks with parallel sinuses. So it's her first presentation during the Ocular consultation. So post-discharge, she has been referred to the cornea clinic for both the generalized swelling with the peripheral infiltration and the conjunctival epithelial defects. So these are her presentation. During the right and left, you can see the obvious infiltration was there, and there was a conjunctival and the corneal epithelial defects. So OU scraping, both the scraping was done, and which was negative. The CVC, CRP, ESR, RA, and thyroid function test and the ANCA was sent to rule out the underlying collagen vascular disease. A repeat COVID RT-PCR was done, and which was negative. I have started the topical gatifloxacin 0.5% in a 1 hourly fashion, cycloplex somatropin and lupus coverication and low dose of loteprednol with the close monitoring with the coverage of the topical antifungal in spite of having instinct that maybe we are dealing with the underlying mucormycosis. And oral itraconazole has been started by the ENT consultant. And we are advised to do one MRI. So in spite to assess the diagnosis, but after doing the MRI, we are in a much more confused status because there was MRI brain anomaly showing the spheroidal sinus polyps or mucal lesions. So we are in more dilemma. Then CT of the panel sinuses were done, which was normal. Again, the ENT consultation was done. The panel sinuses congestion, but clinically no significant lesion. Physician for the control of DM and to rule out the underlying collagen vascular disease. So in spite of the aggressive medication, patient presents with like these features. So what I am dealing with? Anyone can share? So we have done the repeat scraping was negative, repeat CT of panel sinus within normal limit. Meanwhile, the CVC, ESR, CRP and RA all has come, it all raised. So probably we had an ANCA was negative. So probably we are dealing with the RA related the peripheral infiltration. So physician started the methotrexate with the injection triamcinolone because still he has a doubt because we are maybe dealing with underlying as the patient diabetic and all the periodontal swelling, maybe mucor etiology was there. So he restarted the loteprednol with the close monitoring. And the moderate to symptoms improvement of the patient was there, but significant thinning was noted. Then again we go through the whole clinical finding. We have make a June meeting with the physician, with the ENT consultation, and we are go through the literature. So try to convince the physician that probably we are doing with the the RA-related scleritis, and approximately as per the literature found that 2% of the RA patient may present with the scleritis in the first presentation and the periorbital swelling. So with close monitoring after the consultation of the ENT and the physician, we have started the oral Vizolone in a half dose, 0.5 milligram per kg per day. See, the patient was showing these dramatic improvements, but the both is 6/9 and 6. Once the ascending order of improvement is there, I have started after 1 week, we have started the normal dose, 1 milligram per kg per day, and the patient was doing well. I thought I have done a great job. So patient comes recurrent on and off after 2 months, like these pictures. So at this patient, what done my next? Because that time already said COVID has gone, patient was under all systemic methotrexates, and surface was quiet, but you can see the very panicky surface is there. And patient come every time, I also putting some the low dose of steroid, patient was doing well. But in spite of all the medication, patient every 2 to 3 months, she is coming the red eye, and I am not happy with these medications. So what will be the next? So we have started the topical cyclosporin for this patient, and the patient and continuing this for last almost more than 1 year, what Dr. Shorto was dealing with, 0.05%, and the patient maintain these things, visions, BCV 6/6 and 6, and is now with happy patients, and regularly in the follow-up also. So these are one of the indications for how some diagnostic dilemma, and after that once it achieved, then again the surface inflammation was there. So this is one of the, we needed some of the immunomodulator to reduce the surface inflammation in the creepy eyes. So now I am dealing with my second cases. There's a dousing the fire.
John, just one quick question to Bhaskar Shamurda. Like this kind of situation, only topical can take care of it, or a systemic rheumatologist intervention is very much needed. Otherwise, again, this can recur.
Rheumatologist involvement is always required in this kind of cases, because many times systemic therapy is required, and a proper rheumatological diagnosis is also very important.
Exactly. These patients are already under the methotrexate by the Arup Kundus, well-known rheumatologist. In spite of that, he has on a very unstable surface. Then we have started the topical cyclosporin, and
So the merit of this case is even with the control of systemic parameter properly. So you may have the continuous progression of the cases, which can be controlled by a topical immunosuppressive or a immunomodulator.
Yeah, exactly. In spite, whenever there is it depends on the topical steroids. Then you have to understand this after 2 cycles, if it keeps on going on. So better to patient need to mobilize the ocular surface by some of the immunomodulator, which has the maximum effect with the minimum side effects. So we can rely on the cyclosporin like that, 0.05%.
So in that situation, instead of adding one more systemic drug, you can start with the topical drug and see whether it is getting controlled or not, and then accordingly to
exactly.
Okay.
We'll curtail the side effects, systemic side effects of the systemic drugs also.
Okay. Thank you. Next
sir.
case.
Thank you. So I will just move on to my second cases. Already before that, Vanati ma'am nicely explained the things of sacrifice reconstruction. This is one of the cases. That kid came to us with a plastered eye. They had a history of Chuna injury almost couple of years back. Then he was in on and off redness, and under the treatment of some of the topical steroids and lubricating eye drops. But he has a very inflamed eye intermittently. So we are planning to do some of the ocular surface reconstruction for these kids. Dissect the subconjunctival tissue, releasing the pannus, and preserving the conjunctiva, healthy conjunctiva as much as possible, which I have learned from my surface team. It's very simple. We don't need any extra additional instrument investment. We can do it because all of our we're all our cataract surgeon. We have simply by crescent we can do it. We put a AMT, which will act as a basement member enter whole ocular surface, secured by fibrin glue. As the other eye already have healthy, the prior consent has been taken from the parents. Placing the slit bits, sparing the visual axis, secured by fibrin glue, and followed by basal paste and tarsorrhaphy has been done. So my immediate post-op was uneventful. As there is tarsorrhaphy, we can see the little bit of slit bits and the surface was white, no evidence of infection. After 30 days, the eyes like this. The kids having the 6/36 vision. So we have started the occlusion therapy other eye. Meanwhile, the problem is that we lost the patient for the COVID. So when he came to us, again there is a on and off inflammation going on. So we're putting the steroids, but unfortunately the kid is a steroid responder. So each time putting the steroids, we have to clubbed up with the topical AGM. So how to manage these cases?
Rather, I will put to in the. Suppose you have done this surgery and the patient is, even in this COVID or non-COVID situation, patient is way out for 2 hours journey, so they are not able to come routinely to you. So what will be your advice to the general ophthalmologist who is seeing in the periphery of this patient if they follow up? So what should be the follow-up schedule? What are the things they should look for? And if any, what are the signs of early complications so that they can send it to you?
So you are asking that patient has gone and then didn't come, and they are getting checked by this local ophthalmologist in somewhere. So in that cases, you have to see this integrity, how this amniotic membrane is maintained. First thing, these pieces of this that limbal particles, they are dislodged or not. All those things you have to look. And if it is there, if it is say after 2 weeks, usually it gets dissolved. So if it is there, then you then look for this. This patient was a steroid responder.
Yeah, he is a steroid responder, sir. Actually, initially during the COVID, he lost the follow-up, and mom is super mom. So she started by her own, that she knows this medicine causes the reduction of the redness. So she started by her own 4 times, 3 times regularly.
So usually these steroids should be given maximally 6 to 8 weeks. So if this patient, sometimes they keep on going, keep on just putting these drops, then it may cause these problems. So in that cases, only thing is that you have to ask the patients, or you can go, talk to this general ophthalmologist that you should put this surface, that means only by lubricating drops, nothing else.
If the patient is on, if that boy is on steroid, so one is even in the periphery better to check IOP if possible, number one. And number two is to look for the surface or what changes they should refer to you back again. So any kind of new addition or symblepharon starting again, that is the sign or
No, thing is that actually, if there is this, again this panas, this coming out, again recurrence is there, then you can see that this luster of the cornea is again lost. Then you have to come, that's the thing.
Okay.
So actually, what I want to share these things. This patient comes with on and off redness, and already mother understood this medication causes that they have started the self-medication. So there was meanwhile the shoot of IOP is there. We controlled it by the glaucoma consult to the consultation. So I have started this patient. So I have started this patient the topical cyclosporin. And first initially start with whenever he came to very inflamed eye, what the Dr. Shweta was telling that we have to, we know that T cell suppression needs at least 2 to 3 months to start this action, cyclosporin. So initially start very loads of steroid and just dramatically they can get the redness subsides. Then we clubbed up with this addition, start with the cyclosporin 0.05%. Whenever the steroid stop it, we tap and stop it. By that time the cyclosporin starts its action. So and we ask the patient, you can continue these things. So no harm for that. And we routinely follow up. Meanwhile, in spite of that redness also, then you can come for the emergency basis or consult with the local general ophthalmologist. Because we can't give this patient for long time only the lubrication. They have a tendency because we have done the extensive surface reconstruction. So they need some of the immunosuppression.
Correct. So can we move on to our last case presentation?
So is the last So this is me and myself. So this is a very case. I hope some of the opine from the whoever said. So this patient referred from one of my friends, general ophthalmologist. This is a very clinical obvious case of the OSSN. So there is a associate showing these things. So I have started the MMC 0.04%, 2 cycles, and after that followed by INF that 1 million international units. Then you can see obviously the patient after the 2 months it is resolved. and patient maintain all this with this quite ocular surface, no tumor for the almost more than 1 year. Then he come for the follow-up, and then a significant cataract was there. Then almost after 1 year, when there was no recurrence is there, we have done the thorough clinical examination, including the ASOCT and gonio and everything. Then I have done the cataract surgery. This is immediate post-op, and that's after 2 months. And I was very happy. The patient was very happy. There is no recurrence, and we have done I'm doing great job for the patients. Then I got a call after 3 months from a daughter that they are from outside of the West Bengal. So she came with this picture. That's the recurrence of the tumor. So at the specifically, I have made a side photo over there. So I was so scared and started again the MMC 0.04%, and the patient was dramatically improved. But I was happy. Then I sent back to home. Then after the second complaint, they come back to these pictures, the sudden drop of vision, and this is how the surface is very ugly. So my question: how to resolve these things?
Question straight away goes to the panelist.
In acid alkali burns, we are applying amniotic membrane, and it has got no immunogenicity next to. So in that case, steroid will not be a problem. And
yes, sir. This is one of OSSN. This is actually, I'm just go through the file rapidly. This is the first picture. Then first we have done the first time we have done a MMC 0.04%, 2 cycles followed by interferon 1 million international units. And this is after totally resolved after 3 months, and you can see the ASOCT. Then after 1 year, I was doing this is the cataract patient at the NS4, and then this is the immediate post-op. The cataract surgery is done. Then after the 2 months of the cataract surgery, and the patient absolutely doing well. Last episode, whenever I gave the MMC, that time there no surface inflammation was there. But after that, just after 1 month, the patient, 3 months of the cataract surgery, they came with the second recurrence of the OSSN. Then we have started the 0.04% MMC, and the lesion was resolved. But after 1 month, patient complained of this thing. Sir, only 2 cycles. Only 2 cycles. 0.04% QDS for 1 week, then 1 week off, then another cycle started. Only 2 weeks, sir.
So this is, I feel that's this because of MMC induced toxicity.
No, that
we
is
have to rule out recurrence versus toxicity, because if it's MMC toxicity, it might be inferiorly more actually, whether the punctal occlusion was done or not done,
it's
and
done,
whether the steroids
I follow the
and
same protocol, ma'am.
lubricants.
It's done, ma'am. It's inferior, ma'am. It's inferior. It's a rule of
If
thumb. I have done that.
inferior-
Still, I follow the SN protocol, ma'am.
Inferior means it can
Inferior,
be
ma'am.
toxicity. MMC.
Yeah, it's an inferior.
So we
ma'am.
would like to start steroid.
Yeah, already
and see.
initially start clubbed up with the top low dose of loteprednol. But in spite of the what I have doubt, because first time this patient first episode I have treated same fashion, that MMC 0.04%. That time there is no that type of toxicity. It would be the surface toxicity. The second time why suddenly there is a surface toxicity. Not a SL, ma'am. Any comments? Couple of weeks back we have lots of discussion in the cornea group.
Using a topical with a BAK, so if you use an antibiotic with a preservative for 1 week, it will be fine, but if you use it for 3 weeks, it's going to cause toxicity. So it's probably that. So and the patient has undergone cataract surgery, intervention after that as well. So I think it is just a surface inflammation. Like Dr. Mona said, I agree with her. If the tear levels are adequate, which the TMH shows it is, probably just a short course of topical steroid, reassess the surface. But if it still persists, then there is some subclinical inflammation which is present, and probably a role of topical cyclosporin, a low dose can help if despite topical steroids it is continuing.
Yeah, actually I'm just highlighting what I have faced this patient. So can I just ask the panel, can it be like the type 4 hypersensitivity? Because first time it was because I have some sorts of the MMC related. Because first episode it was not that, 2 cycles even. After the second cycle, suddenly it has a very flare up the things. So I have started the topical definitely, ma'am, loteprednol, but in spite of persistent, then I clubbed up with the 0.05 cyclosporin. It is especially of the 2 days launch of the medicine, whatever, but I have started the things. and really dramatically showing the improvement is there. And still the couple of months I'm continuing with the, now presently patient only lubrication, and his surface is absolutely quiet. So ocular surface disease are a large group of the disorder with the varieties of the etiology, symptoms, and the clinical finding. Whatever the initial etiology factor of the ocular surface disease, once the disease has been developed, inflammation becomes the key mechanism of the injury to the ocular surface. Topical and systemic corticosteroids are the commonly used medications to address the surface inflammation, but having the serious side effects. Topical cyclosporine is a proven medications with the minimal side effects to address the surface inflammation of the various etiology. And the surface reconstruction and the medication should be in the molecular and the cellular level. I'm just concluding these things, and thank you very much. Thanks for your patience sharing. So I'm really thankful to our chair of the cornea, Dr. Pema Padmana ma'am, for giving us the opportunity for learning. And obviously the ocular surface team, Dr. Jika Gitayar ma'am, Dr. Sweta obvious there, Dr. Vesvaisen, who gave us the hands-on training during my fellowship time. Thank you very much. Thank you. Thank you, ma'am. And obviously my basic learning teacher, Dr. Mona, is there. She is also my teacher. Thank you, ma'am. Thank you.
Fantastic evening to start with as an academic session of this 2023, and would like to thank all of you, those who have taken time to come here. But before that, there is a routine memento distribution procedure has to be done, which is customary. And I would like to request our president, Dr. Ratish Chandrapal, to hand over the memento to Dr. Namrata Sharma, please.
It is a kind of oil, Bishohori tel. Bisho means it is toxic. So Hori means Haran Kara means it will take away all toxicity. Don't think that cyclosporine is a Bishohori tel. Everything is happening that everyone is telling cyclosporine is cyclosporine. Cyclosporine has its own drawbacks also. You must realize that, and it is not a magic drug. Thank you.
Thank you. Thank you, Namrata. This is the take-home message of this is a good one, but again you need to use it cautiously. I would like to request our immediate past secretary, Dr. Shubhashish Nag, to hand over the memento to Dr. Santosh Bhonavar, sir, please. Thank you so much. I would request one of our past president, Dr. K.P. Ghosh, sir, to hand over the memento to Dr. Vanati, please. এগুলো যা ডিসকাশন হচ্ছে প্যানেলের ওখানে এগুলো সব আউট অফ দ্য টুডেজ প্রোগ্রাম ইজ ওভার, সো ইউ ডোন্ট নিড টু হিয়ার দোজ ঠান্ডা জলের ডিসকাশন. Big round of applause for them. I would request Dr. Devashish Das to hand over the memento to Dr. Shweta, please. I'd request one of the senior teacher, Dr. Devashish Dotto, sir, please hand over the memento to John. Can I request one of our past president, Dr. Parag Mukherjee, sir, to hand over the memento to our Dr. Shamorda, Dr. Shamar Bashak. এটা ওই ঘরে ঘরে দেওয়া ব্যাপারটা. I'll request Dr. K.P. Shaha to hand over the memento to Dr. Bhaskar Rai Chaudhuri. I'll request Dr. P.N. Biswas sir to hand over the memento to Dr. Sanjay Chatterjee. Again, this is chosen oi ghore ghore motoni. Two stalwarts of RIO Kolkata. From retina to cornea. Can I request Dr. Mrinal Kanti Ghosh, one of our senior professor, Mrinalda, please hand over the memento to Tuhin, Choto Bhai, Paraduto Bhai. And can I request now Dr. Maitreyi Das to hand over the memento to Dr. Mona Bhargav. This is the women power. And now I would like to hand over the memento to the day's moderator, Shumana. So I would like to thank all of you again for making this evening a big success. And special thanks to the panelists, those who are actually has made this scientific evening even more attractive. I would like to thank our academic partner in TAS for this, and none other than Apurbo, Giri, each and everyone for all those background support. Without that, this is not possible. And even for the last moment changes for the Novotel personnel who is present here. I would like to invite all of you, for this cocktail dinner, and have a great weekend today. Can I have a quick photograph of all the speakers and the panelists on stage?